Good evening, everybody. My name is Brandon Wainwright, and it's my privilege to be the director of the Institute for Molecular Bioscience, or IMB as we call it, at the University of Queensland. As we start the proceedings, I'm just going to say a few opening remarks, and first of all, to acknowledge the traditional owners of the land upon which we meet today, which is the Jagera and Turrbal people, and to acknowledge elders past and present. I'd also like to acknowledge our distinguished guests, Professor Charlie Teo AM, Director of the Centre for Minimally Invasive Neurosurgery and founder of the Cure Brain Cancer Foundation, Mr. Barrie Littlefield, also from the Cure Brain Cancer Foundation, who's the Head of Engagement, our facilitator, and we'll give Madonna a little bit more of an introduction in a moment, Madonna King, my UQ colleagues and my Deputy Director of Research from the IMB, Professor Jenny Stowe, and my colleague in the University Senior Management Group, Professor Nick Fisk, who is the Dean of Medicine and Biomedical Sciences. So, ladies and gentlemen, IMBers, members of the community, patients and supporters, welcome. Welcome to this great event, which is beating the odds against brain cancer. So for those of you who are not aware of the IMB and its work, the IMB was the first and is the largest of the University of Queensland research institutes, consisting of around about 500 researchers and support staff. We concentrate in a number of research areas, cancer, and some of you may have seen that over the last year we have unveiled through publication the genetic roadmap of pancreatic cancer, of ovarian cancer, and my own special interest is in paediatric brain tumours. We also work in looking for new antibiotics against superbugs, inflammation research, looking for rare disease genes for Mendelian inherited disorders, but tonight is about brain cancer. So I think we're going to have a little bit of a panel chat, but to get us kicked off, I would like to introduce to you our award-winning and we're very well-known interviewer. Well, interviewing is a bit harsh tonight, Madonna King. Madonna, as you know, is a multi-award winning journalist, broadcaster, author, and recently biographer. So we look forward to hearing Madonna and Charlie have a chat. So thank you, and we'll see you later.
I don't feel any pressure at all, Professor. Look, thank you, Professor, and thanks for coming along. You know, this event sold out so quickly that not only have we filled Auditorium 1, I'm just waving to everyone across the aisle in a filled-out Auditorium 2. And that interest in National Science Week, I think, is driven by a couple of things. One is your interest in this subject, whether you're a clinician, a patient, a researcher, a family member, or a community member. But it's also a barometer of how highly you regard our panel, our guests tonight. So let me move straight on to Professor Charlie Teo AM. As we all know, Professor Teo is an internationally renowned neurosurgeon and a pioneer in keyhole, minimally invasive surgical techniques for brain cancer treatment. He founded Cure for Life Foundation, now Cure Brain Cancer Foundation, in 2001, and this is now the peak brain cancer organisation in Australia, focusing on research, advocacy and awareness. So as Brandon said, we're going to have a brief chat before Professor Wainwright and Barrie Littlefield join us, and we're going to get through as many questions of yours as we can. So first of all, can we have a big welcome for Professor Charlie Teo?
Thank you.
So much warmth in this room for you, and we don't know much about your background though. I know you were born in Sydney, you grew up, you were educated there, you did medicine there, but who was the little Charlie Teo, the 13-year-old?
Well, I can sum it in 2 words, I guess, because my mother claimed, and I actually have witnessed it, that my school reports used to always come back as Charlie has done well at school again, but remains noisy and boisterous.
Nothing's changed.
No, nothing's changed.
So did you find school easy?
Well, I was never really intellectual as such, so I didn't like reading books, and I kind of was interested in the subject, so it's not as if I breezed through school, but I didn't put too much effort into it, and I managed to just get through.
And you were drawn to science?
No. I was drawn to the humanitarian type subjects. I did well in first level English and history and did poorly in first level science and mathematics.
So what happened? How did you end up studying medicine?
When I left school, I wanted to be a mechanic. I knew that I was good with my hands, and I liked motorbikes, so I chose to be a mechanic apprentice, and I did that for about 3 months, and then I was treated very poorly by the customers, who would sometimes think that I couldn't speak English and treat me like I was an idiot, and I didn't like that, so I wanted to do a job that I felt would give me a bit more status. And so yeah, I actually got into medicine with my marks, so I decided to do medicine, and after that.
Wow, and you went home to your parents and said, "Oh, look, I've decided to be a doctor." What was there?
Yeah, they never really encouraged me to do medicine. I was in the school debating team, so I wanted to do law at one stage. I wanted to be a politician. I wanted to be. I had my black belt in karate, so I wanted to be a bouncer. I wanted to be in charge of my own security firm, and all these sorts of things. But no, never medicine. And then I don't know. It was just one of those things that I guess I fell into it. I knew that I liked people, and I liked doing things with my hands, and so the two almost just, it was a natural fit.
And that could be quite a few things in the medical area. When did neurosurgery show its face?
Again, it was one of those serendipitous things. I didn't enjoy neurosurgery as a medical student or as a young doctor. I can remember the system at Nepean Casualty was such that when a patient came in, they'd put their chart on a pile, and the doctors would come along and just take the first chart off and call for the patient. And if I ever picked up the chart and saw something neurosurgical, I'd just slip it underneath and I'd go for the next chart, because I just was fearful of neurosurgery. I knew that it was one of those specialties where if you made a mistake, it'd be sort of unforgiving, and I wasn't prepared to put myself under that stress. I didn't enjoy it. I didn't know much about it, and so I wanted to separate myself from neurosurgery. So I started doing paediatric surgery. In fact, I came up to Brisbane for a year and studied with Tat Hong, doing liver transplantation, and I wanted to learn how to do liver transplants, and fortuitously the neurosurgical registrar fell ill, and they asked me to cover his work, and so I was thrust into neurosurgery and loved it. As soon as I started learning about it and knowing more about it, I loved it.
Tell us about your first patient.
First patient was actually a neurosurgical patient. Isn't that weird? Yeah. So you could volunteer to go to the casualty department at Prince of Wales Hospital. It wasn't part of the curriculum, but if you were keen, you could just go there and see the patients. And I can remember the first patient came in with a head injury, blown pupil, which means that they've probably got a blood clot. And in those days, we didn't have a CT scanner or an MRI scanner, so the only way of diagnosing which side the blood clot was on was by the blown pupil. And so if the blown pupil's on the right side, you drill a hole while they're there in the emergency room in the right side of the head and let the blood out. But we did that and no blood came out, so we had to turn him over and drill holes on the other side. And it was pretty gory, but I loved it. Didn't turn me off at all.
Patients come from all over Australia, New Zealand, US, Britain, Southeast Asia, Europe, to see you. In addition to that, I know you give up a few months each year and you travel to educate neurosurgeons in other parts of the world, like Peru, Indonesia, Vietnam. I want you to tell us about a couple of the patients who stole your heart. I know it's a hard question, but...
Well, it is a global practice. I have an appointment now at Duke University in North Carolina, where I operate on my American patients. I have an appointment now at National University in Singapore, where I operate on my Southeast Asian patients, and I have an appointment at Stuttgart University in Germany, where I operate on my European patients. It's hard, Madonna, because every patient teaches me something. And there's a few patients in the room here tonight and a few relatives of patients, and I remember them all. I know that sounds a little bit boastful.
I know that because we were sitting over there, and you could point to people and say, yeah.
So I think every patient adds something to my learning about human nature, about the disease, about how to conquer the disease, about about humanity itself.
So tell me, what has a patient taught you? What are some of those lessons?
Well, they teach me a lot about courage. To do something different, to swim against the tide, you do have to have broad shoulders. And since I introduced, I'm still in the process of introducing keyhole surgery to neurosurgery, there is a lot of naysayers out there and a lot of people that say I shouldn't be doing what I do and that I offer false hope and all those sort of cliches that they use. And I must say that my patients teach me that it's not wrong to challenge the status quo, and all it takes is courage and sort of honesty and self-auditing and all sorts of things like that. But it's the patients that give me the strength to do that.
I'll come to that clash with the establishment in a moment. But just on that line, how hard is it to stay emotionally detached in the job that you do? Because you know these people.
Yeah, no, I don't stay emotionally detached. And again, it's been a major criticism of my colleagues that, Charlie, when I failed the exam, I didn't fail it once, twice, I actually failed it 3 times. And so I sat down with my mentor and I said, Michael, what am I doing wrong? He goes, Charlie, he took off his glasses, he goes, Charlie, there are 3 things that I think that you need to really address. And one of them was stop riding my motorbike. And the other one was stop clubbing and going out, sort of burning the candle at both ends. But the third one was, you've got to stop calling people by their first name. And you've got to stop getting people to call you by your first name, because it's going to, it's not right. And I guess what he was trying to say was that in many ways it's quite protective to create a barrier between you and your patient so that it doesn't emotionally destroy you by keeping that distance. But I must say that I ignored that. I stopped to pass my exam, and then once I passed my exam, I started being the same old Charlie Teo, which was getting to know my patients very well.
Still ride a motorbike?
Well, I stopped to pass my exam, but then I started riding.
And I know your beautiful daughter, Alex. Where's Alex? Just put your hand up. Your beautiful daughter's in the audience. You have stopped clubbing, haven't you?
No, I actually still like going out to nightclubs and stuff. Yeah.
Good on you. Good on you. Well, you mentioned, sometimes you go up against the establishment. I've heard you described as a maverick, and I've heard you described as a miracle worker. Where do you sit there?
Yeah, well, I'd like to think that I wasn't a maverick. And Genevieve, my lovely wife, who has supported me 100%, she yearns for the day that I'll be I'll be the status quo, and that I won't be considered a maverick. I mean, I thought a maverick was someone who sort of threw caution to the wind and was a little bit irresponsible and all that kind of stuff. But, the stuff I do, I always do in the best interest of my patients. I always say to myself, look, okay, it's new, but I think the old way was no good. And if I was that patient, I would want my surgeon to go, even if the books say it can't be done, I'd want you to have a go if you think you can do it. And so, some people call it being a maverick. I call it sort of obeying the wishes of my patients, really.
Before tonight, lots of people sending questions. I'm going to steal one from Sofia, who said, because it follows along these lines, when faced with patients who require high-risk surgery, how do you go about deciding whether or not to carry out the procedure?
Oh, that's easy. It's all about honesty with your patient. So, when I first did this operation called a pallidotomy, it was years and years ago when I was in America. It's nothing to do with brain cancer. My first patient, I go, look, I've never done this operation before, but they say it's pretty good and I've learnt the technique and I'd like to try it on my first patient. Are you willing to be the first patient? And he said, absolutely no way. So that was it, done. And then, so the next patient comes along, I say exactly the same thing. I've never done it before, I'm going to try my hardest for you. I've been trained to do it. And would you like to be the first patient? Yeah, go right ahead.
And how did it go?
Then the next patient can say, look, I'm very experienced at this operation.
As long as the first patient worked out.
Yeah.
That's right. Yeah. So what's an average day for Charlie Teo?
Well, I'm an insomniac, so I get up. Alex wants me to get a bit fitter, so I now have a trainer that trains me between say 6:15 and 7. And if I'm not with him, I go kayaking because I like kayaking on the harbour. So I like keeping very fit. And then I get to the operating room where I've got a fantastic team of people who help me, and they've got the patient prepared and the X-rays up and everything ready to go. And then I operate often between 8 o'clock and 2 or 3 o'clock in the morning, just the whole day. And then I have a few hours sleep and do the same thing the next day. The next day I see patients, and then the next day I operate again. The next day I see patients.
And many in the room will know this, but some won't. How long might one operation take?
Well, unfortunately, with my reputation, I get all these really difficult cases coming from all around the world, and so they can be as long as... We did one yesterday or the day before that took 10 hours. And that was 10 hours of absolute concentration. It was really difficult. There was big blood vessels and blood was going everywhere, and it was deep in the brain. And thankfully, he did very well. But that's a difficult one. An easy one is about 2 to 3 hours. And the longest one I've ever done is 26 hours.
26 hours?
Yeah, it was crazy. But she did. It was a 15-year-old girl that I did in America. And I took a break at midnight. Another neurosurgeon came in and took over, and unfortunately got some terrible bleeding. So within about 20 minutes of me having a break, I had to sort of rush back into the operating room and finish it off. And it took 26 hours.
And how's that little girl going now?
She was cured. It was a benign tumour. And
brain cancer doesn't actually have the profile perhaps of breast cancer. How hard does that make it to raise funds and for there to be a level of community understanding?
Yeah, no, it's very difficult. It's very difficult. If it wasn't for people like Barrie, Littlefield over there, and half the people in this room who've helped me raise money, it would be impossible. So you need to get people on board as well. It's not a common cancer. Yes, it has an impact on society that rates number 1 in every society. So not only here in America, but also developing countries, brain cancer has more impact, socio-economic impact on society than any other cancer. For that reason alone, it should get the most funding. Well, there's another fact that it kills more children than any other cancer, and it kills more children than any other disease. So with those facts, you would think we'd get the number 1 funding. We don't. We get the least amount of government funding, and we get the least amount of funding from NHMRC. So we are so dependent on grassroots community support.
This probably won't surprise you, but you heard Professor Wainwright ask people to turn their mobiles to silent.
Yes.
Often we're told to turn them off, and I'm stealing, I think, more than a dozen questions that came in to our panel, and thanks. The first one was from Marlene for this. Do you think mobile phones cause brain cancer?
Yes, I do. Well, the jury is still out. I'll tell you 2 reasons why. The first reason is that we once had a speaker come to Australia who was telling us that there's no relationship between brain cancer and mobile phones. And he, I forget his name, I'm sorry, but he was a reputable speaker, an authority on the subject, and his job was to make sure that people weren't too worried. And I went up to him after the talk and I said, "Hi, my name's Charlie Teo." I didn't know who I was. And I said, "I'm a neurosurgeon who has just operated on a patient with GBM, a brain cancer, and his 3 partners, he had a trucking company, and they were on mobile phones, 8 hours a day, 6 hours a day, the old bricks. He got brain cancer. His 3 partners, all unrelated, they're not family members, all got brain cancer and all died. And the secretary of the company got brain cancer and died. And I said, surely that is something to do with the fact that they were all on mobile phones, and he said yes. So yes, he did. He goes, "Look, I realise that many of the old mobile phones that had very high wattage and emitted a lot of power, they were probably instrumental in causing brain cancer in all those people. But the phones that we have these days, no, they don't produce as much."
Do you limit the use of your mobile phone?
Yeah, no, I don't even carry. I try not to carry one, and when I do, I always put it, excuse me, and walk outside and put it on speakerphone, so I keep it away from my brain. But that's one reason, and the other reason is the Interphone study, which is a major study that everyone quotes to say there's no link between brain cancer and mobile phones. It was a $45 million study, funded unfortunately by industry, but no one else would fund it, so you can't blame them. The null hypothesis for that study was that brain cancer does not cause mobile phones do not cause brain cancer. So that's a null hypothesis. And the conclusion was that it was right. There was no link between brain cancer and mobile phones. The small print in the Interphone study is frightening because it showed that if you were a high usage mobile phone person, in other words, more than half an hour a day, and if you looked at the site of usage, then you were 2.4 times more likely to develop brain cancer on the site of usage if you use your phone for more than half an hour a day for 10 years. I contend that most children these days use their phone for more than half an hour a day. So, I'm very worried about it, and I encourage people to try and limit the amount of exposure.
You live with your wife and your 4 daughters, I understand? Four daughters?
4 daughters, 5 dogs.
5 dogs? Mm-hmm. Female dogs, male dogs?
Male dogs and 1 female dog.
Okay.
Yeah.
You love riding a motorbike. I understand you listen to ABBA.
Yes, ABBA as well as other,
Yeah. But you
other,
like ABBA.
other groovy sort of hip music.
Yeah, like ABBA.
ABBA.
What don't we know about you? And remember, Alex is there, and Alex, if he's not truthful, I'll just bring the microphone over to you, hey? Tell us something about Charlie Teo we don't know.
Well, I'm not saying this to be humble, but I'm not a saint. People sort of, they think because I, save lives and I do what I do that I'm sort of this great person, and people are lovely. They come up and say, "Oh, we just love you, and you're great." And I'd like to tell people that I'm not that great. I mean, I swear at people and I have road rage, and
I'm liking this. Keep going.
I think I'm just very human, and.
So,
it's been great. I love the accolades, and I'm not going to say I don't like them. When I got the Order of Australia, it was lovely, and being asked to give this interview up here and being asked to give the E.S. Myers lecture a few years ago, I love that. And but one day I think I might disappoint people because when they find out that I'm just like everyone else. So I don't want people to put me on that sort of pedestal where they think I'm great.
You told me a great story just before we came up here where you were on stage at Government House getting an award and someone fights their way through and says...
Yeah, so the person who fought their way through was the UN ambassador to Australia. And,
And you were a bit pumped up. You were thinking he's really excited about meeting you.
I was getting an award. Everyone wanted to meet me, have their photo taken with me, so I thought it was all about me. And so this guy comes up and I think, yes, the UN ambassador wants to meet me. That's very nice, very nice. He comes up and goes, are you Alex Teo's father? And it transpired that he'd met Alex at school. Alex had asked him some pretty hairy questions, and he was pretty impressed with her and wanted to meet the father of Alex Teo. He didn't know who I was.
Put you in your place, though, didn't it?
Right.
Well, we want to thank you so much for coming and just being so generous in your answers. And I'm going to put it in the words of a couple of people here. Peter, who wrote, I read the book Life in His Hands, a true story of a neurosurgeon and a pianist. I want to say thank you. This book was inspiring and has helped me immensely. And this one from Trudy. Charlie performed a craniotomy on my son when he was 12. He's now 23 and working as a mechanical engineer in India. The world is his oyster, thanks to Charlie Teo. Ladies and gentlemen, could you please give a big round of applause?
Thank you.
And can I get you to stay there, and could I please invite Professor Brandon Wainwright and Barrie Littlefield to join us up here, and I'm going to start this, but I'm going to welcome your questions and your tweets. You can tweet your question or your comment, if you've got a comment, using the hashtag beating the odds, and if you can also tag at IMB at UQ. So Barrie, can I start with you? You work for Cure Brain Cancer Foundation. You are a great advocate in this area, but you're also a dad. I want you to tell me about Eloise.
Sure. Well, Charlie knows Eloise. She just a regular girl, obviously my daughter.
She wasn't.
Just full of life and happiness and brightness for everything and everyone around her. And, one day we found out she had a brain tumour. And unfortunately she didn't make it. She lasted a little bit longer than average for somebody with a GBM, a glioblastoma that she had, which was about 16 or 17 months. Charlie would tell you most people don't even last a year. And that was unfortunate. But as Charlie said, amazingly courageous, and really threw down the gauntlet to me, I think, through that period of time, that I just couldn't let that go at the end, that, she fought really bravely and just bore herself with such dignity and hope. Charlie talks about hope a lot, and she had buckets of it, but, at the end, she just, she went, and so, yeah, I'm here.
Well, and as a dad, can I ask you about the choices you had to make that you never dreamed that you would have to make?
That's a really good question. It's, for those people in the room who are going through this right now or have been through it, and both the people who are living with brain cancer at the moment, but also carers and families, I mean, it's an incredible journey. People will tell you that the first 24, 36 hours are just this whirlwind of emotion, you can't quite get a touch on reality. It's just an incredible time to find out that, your son or your daughter, or I'm sure your mum or your dad, or, your brother or your sister has brain cancer. And then the decisions that have to be made in such a short space of time. And I was from a healthcare background. I'd actually done some work with Charlie about 10 years earlier, bizarrely, on brain cancer, and around the introduction of the only chemo for brain cancer that we still have, temozolomide. So I kind of knew something about it, but even for me it was an incredibly difficult time. The choices that had to be made very quickly, and they're all grey. So there's no, it's not like some other things where, sorry, I keep on quoting you, but Charlie would say, like, if someone has breast cancer and they get sat down by the surgeon or the oncologist and they say, look, this is what you're going to start with, this is the choice here. If that fails, you've got this choice. If that fails, we go to this. And if that fails, we go to this. Brain cancer, there's one option.
Surgery.
Well, we've got surgery, radiotherapy, and one chemo, and that's it. So, and the choices between those, do you do surgery? Do you not do surgery? Do you radiate? Do you not? If so, when do you do it? Do you do it concurrently with chemo? Do you not? And as a layperson, all of these things are pretty overwhelming. So. And
you have to put your hope and your future and your hands in your doctor, your neurosurgeon in that case, don't you?
Absolutely, and the neurosurgeon and the oncologist and the whole team, I mean, you are in their hands very much.
You just mentioned about brain cancer and how it differs from breast cancer. Can I throw to Professor Wainwright and broaden this a little bit? Because I guess on this panel we've got the clinician, the researcher, and the advocate. And Professor Wainwright, just tell us a little bit. Every cancer is different. Who's at risk of brain cancer? How does it manifest itself?
Difficult question. I mean, how it manifests itself is that cancer is a disease caused by damage to the DNA, which is inside all of the cells in our body. It's a chemical, and think of it as the software program inside each of our cells. And when we start out our life, and we have an egg and a sperm, and then we turn into 2 cells and 4 cells and 8 and 16. Eventually the program says, no, you're going to go and become a limb, and you're going to become a muscle, and you're going to become a bit of the brain. And then we form. And that set of instructions works very well. But cancer is a disease where the cell no longer recognises its instructions. It forgets where it is. It doesn't recognise what it's meant to be, and that's because of accumulated damage to the stuff called DNA, the software. And so that can happen by people who are born with some slight predisposition. Tends to be a bit more common in children, as we've already heard from Charlie, that brain tumours are the most common cause of disease-related death in kids. But understanding the genetics, cancer is a disease caused by damage to the DNA.
And how advanced is research into brain cancer?
Oh, well, the other thing is that every tumour is a completely separate disease, and even within a particular... So the disease that we were fortunate enough many years ago to discover the first gene that caused a paediatric brain tumour called medulloblastoma, which is a tumour from a part of the brain at the back of the head called the cerebellum. And we used to think that even these things called medulloblastoma were just one disease. There was maybe one gene, and so therefore maybe one treatment we could try to look for to try to do better than chemo and radiotherapy and surgery. But we now know that's actually 4 diseases. And the same, we're used to the story now from breast cancer that, it's actually multiple subtypes of disease. So each one is its own battle.
Okay, can I stay with you and go to an audience question? Thank you to Grace for this. And remember, you can tweet your questions. If I can just get that back on the screen, the tweet is tag IMB at UQ or hashtag beating the odds, and we'll pick that up. Grace, and to you, Professor Wainwright, essentially how research will change. And her question is, what do you see for the future of neuroscience research?
Oh, well, the obvious thing in brain tumour research, as in most cancer biology, is the ability to look at the DNA, at the software inside every cell, and personalise therapy. At the moment, as Barrie said, we have neurosurgery for brain tumours, followed by chemotherapy and or radiotherapy. And each disease is different. Inside the cells in a tumour, the genetic programs have gone crazy. But each tumour, from each individual, is subtly different. And so our aim is to, rather than use, for example, a chemotherapy, which is effectively a poison, it's a bit like weed killer we talked about before. It just works by killing the weeds a little bit faster than the grass. Our aim is to find out the specific genetic changes inside everybody's tumour and ultimately develop a therapy that's personalised around every single patient.
Well, you've just answered Sarah's question too, and that was about the genetic screening of cancer cells. I saw you nodding as Professor Wainwright was talking. Do you want to add to that at all?
No, not... he's the expert.
Yeah. It hasn't stopped you before.
Yes, but I don't want to make a fool of myself.
All right. Well, the next one's from Frank, and this is for you, Charlie, or Professor Teo. He wants you cloned, is his first point.
I can do that, Charlie.
But he says, in regards to recent findings that MS may have some viral implications as a causative factor, is there any research underway, perhaps this should be for you, Professor Wainwright, underway that may link viruses to other brain pathologies? Who's best to answer that?
I can give you the clinical answer to that.
Yeah.
There was a study out of Sweden, maybe 2 years ago now, talking about a virus implicated in brain cancer. So we do know that you can find a particular type of virus called CMV in brain cancer cells. And in fact, they took out their tumours from their tumour bank, and out of the 250 tumours that they looked at, 249 were positive for this virus. So they decided to treat the patients with an antiviral agent. It's a third-generation acyclovir-type antiviral agent. And the figures were initially very, very good, where it seemed to be effective. But unfortunately, it hasn't held true with other studies that have tried to validate the first study. So we're unfortunately back at square one. But no, certainly we're looking into the fact that viruses may be implicated in the genesis of brain cancer.
And Professor Wainwright?
It's very well established that viruses can cause cancer. There's a great Queensland example in Ian Fraser, whom you know very well, through the cervical cancer vaccine. That's a viral-based cancer. And certainly some can cause cancer if they sit in the DNA and break those instructions we're talking about. So the cell doesn't know that it's a piece of the brain anymore, so it just grows.
I'll come to drug development and a question there in just a moment, but on Twitter, Charlie Teo, fascinating guy, skilled neurosurgeon, but he needs to polish his RMs.
Oh.
Sorry.
Can you see? It's funny you should notice that. You know, my father-in-law, when he first met me, he doesn't like me, and I don't like him. So, and when he first met me, he said to my wife, she goes, "What do you think of Charlie?" And he goes, "He could have had the decency to polish his R.M. Williams." Isn't that it's come back to haunt me.
Perhaps your father-in-law's in the audience.
Yeah.
Yes, that's right. It's your father-in-law in the audience.
I don't have the time to polish.
I think that's your granddad they're talking about.
Alex will come to you for a right of reply a little bit later. Drug development is always a challenge when you're fighting cancer or indeed most diseases. Brandon, can you tell us about how much that is the case here? And is there anything new on the scene that is actually giving some hope?
Drug development is a very challenging thing to do, and as some members of my lab are here, and they've heard me say 100 times, if it were easy, somebody would have done it already. And it's pretty well known amongst academic researchers, but maybe not so well known amongst the community, that on average from discovery, if you've got something that you think cures a cancer in a mouse, say, to actually getting that white powder in the bottle, it can be 15 or 20 years and $1 billion. So it's an expensive and time-consuming process, and it's not because people are slow. There are all kinds of reasons for it we won't go into tonight. But so we just do this one piece at a time, and we were fortunate through the discovery we made some time ago, a genetic pathway called hedgehog, which has got a strange name. Based on that, a drug was developed quite rapidly by a large company called Roche, and that's now in clinical trial for some children with medulloblastoma. So that was done, that took 20 years. So we just do these things, we just knock them off one at a time.
And is a particular country more advanced than any other country? Is there a lot of good cooperation among scientists?
It needs, especially in paediatrics, where you need bigger numbers to see whether you're really having an effect with a new treatment. The international cooperation is outstanding, absolutely outstanding. It's really a big international community. A clinical trial community in oncology is magnificent.
Charlie, is that the same in terms of clinicians, that kind of cooperation worldwide? And how do you see the future of drug development to combat brain cancer?
No, well, it hasn't been traditionally good. I mean, traditionally people have had their own little silos, their own sort of kingdoms that they're trying to develop and their own name for themselves, and they don't communicate well. But I must say that I agree with Brandon that things are changing. And it's been changing over the last, I think, decade with the Harvard Science, open science model, and people are realising that, you know, it costs a lot of money, takes a lot of time, and the only way we're going to really accelerate that those advances is by cooperating, collaborating.
Two questions here from Sarah and Laith, but along similar lines. What advice do you have for aspiring neurosurgeons, and what can they expect on graduation?
Well, I once was asked to talk to a whole lot of students about vocational guidance, and I've never been asked back again because everyone got up there and said, you know, they started spouting how good their own specialties were. Oh yes, you've got to be an orthopaedic surgeon because this and that. And then they got up the general surgeon. Yes, you've got to do general surgery because this and that. And I got up and go, look, do not do neurosurgery unless you are absolutely passionate about it. Because I can't stand all these neurosurgeons that are around who sort of got into it for the wrong reasons and now they're bored with it and they're not good neurosurgeons. They don't communicate well with their patients and they're sort of charge a lot of money and rush through things and don't even really develop any sort of rapport with their patients. And you know, neurosurgery is very, very difficult. It's mentally taxing, emotionally taxing, physically exhausting. And there's a lot of specialties out there that you can do rather than neurosurgery that will, if they turn you on, you know, if you want to make money, do plastic surgery. You know, if you don't want to talk to patients, do radiology. You know, there's all these... Whoops, there's probably some radiologists in the room. I'm so sorry. No, I don't mean that in a derogatory...
I'm just
saying, yeah.
Just don't get to paediatricians, Charlie.
Yeah, that's right.
My wife's sitting in the front.
I tend to put my big foot in it all the time. But anyway, look, if you want to do neurosurgery, you have to. It has to be the only thing you want to do.
Barry's sitting there just shaking his head. What are you actually thinking right now, Barry?
Barry's tried to teach me some diplomacy for years now.
Well, can I say
he's failed miserably.
Yeah, I need to get another job, I think. It's not going to work.
Well, let me throw to you on that. You are such a terrific advocate in this area. What do you want us to go home remembering or thinking or knowing?
Well, I'd like you to know about Cure Brain Cancer Foundation, which, you know, you mentioned that Charlie founded it way back when, and you know, we all got together. Charlie knows this well. We got together a couple of years back had a workshop. We got 40 people all over the world. We tried to get the system in the room. We had surgeons, we had social workers, nurses, but we also had people like futurists and venture capitalists, others. And the whole basis of that, the challenge that was thrown down at that time was that brain cancer survival hasn't changed in 30 years. 30. 30. So how do we do it in 10? And that's where our mission was born 2 years ago, when we decided to take up that cudgel and say, right, we need to do this in 10 years. How are we going to do it? And we're 2 years in now. We've got 8 years left. We've got to get to 50. Our mission is to improve survival to 50%, 5-year survival to 50% by 2023. Now, it's a hugely tall order, and it's almost unprecedented in the NFP land that we have such a set goal with a time and a figure. But, I come from the corporate world, and that's how the corporate world operates. You don't operate on a lovely woolly thing that we're going to, just be in this for the duration and have a job for life. That's not. If we cure this, I often say to people, I don't care where the answer comes from. I don't care if it comes from this room. I don't know if it comes from a cleaner from Bangladesh or a fisherman in Peru. If that answer comes, then, tomorrow we're packing up and we're going to go and do something else. But we're passionate about getting there. We're passionate about bringing people together, about bringing collaborations together, and about doing things differently. What we do know, that the fact that it hasn't changed in 30 years survival, is that we can't do the same thing. That's the definition of madness. We keep doing the same thing, we'll be here in another 30 years. So we're trying to do things differently, we're trying to innovate, we're trying to disrupt across a whole load of things.
Yeah, sometimes the simplest ideas, breakthroughs, I guess, hit you in the head eventually. And so, for example, we spend, a lot of the research community, trying to develop drugs and new treatments and therapies against primary tumours, such as the ones that Charlie takes out. And pretty much in many cases in brain tumours, they're treated pretty well by surgery and chemo, and there are side effects of all these things and radiotherapy. But you could say they're treated pretty well. But the problems arise when the tumour comes back as a recurrent tumour, or it spreads throughout the body, and so as a metastasis. What we're now realising, and it's a kind of obvious in retrospect, that as we look at the DNA within the tumours that come back and the tumours that recur even at the same site of surgery, they're quite different. And so for decades, cancer researchers have been trying to develop drugs against the tumour, because you go and you say, Charlie, could I please have a sample so we can try to find the genes and then try to develop a drug? Maybe that's not what we should be doing. And so really simple idea, big paradigm shift. So we're constantly trying to chew over these things. What seemed obvious to us yesterday, conventional wisdom is an oxymoron, what seemed obvious to us yesterday, maybe it's not so obvious.
And that's what you're meaning when you swim against the tide a little bit too, isn't it? Think outside the square.
Yeah. It is very hard though in medicine, because we're taught that you've got these parameters by which you should be sort of recommending treatments. You need consensus, you need evidence-based medicine. But the trouble is, if you wait for the evidence, the evidence is not there because it's never been done before. So to do something different, you have to actually not have any evidence. And then consensus, if we try and get consensus on these things, you're not going to get it, because again, you're doing something completely different that's going to actually irritate some people, and
So on that point, I want to open this up to the floor. So don't go home thinking I could have asked Professor Teo a question, or Professor Wainwright, or Barrie Littlefield a question. If you could just stand up and we'll get a microphone to you, and who would like to go first? Thank you, sir. So if I can just get a microphone to you so that everyone can hear it. And who else has got a question? If you can stand up, we'll get the next microphone to you. Thank you.
Yeah, but if they've got a brain tumour, they might not be able to stand up. So.
Oh, I'm sorry. Yes, or yell out. Yeah, let me know. Raise your hand.
And if it's a member of my lab, I'll see you on Monday. Sorry.
Hi, my name's Andrew, and I'm one of the fortunate ones in the room that I don't have a brain tumour. My wife did. But my question is about, I've heard there's been some successful clinical trials in America with immunotherapy and the polio virus, where they actually focus in on inoperable, cheap-seeded tumours, and they've had success with it. And I just wanted to know if you've heard of that treatment.
Well, that came out of Duke University, where I have an appointment, so I can give you first-hand knowledge of that. It was brought to the public's attention through the media, and probably way too early. They interviewed Henry Friedman, good friend of mine, great colleague, very smart man. But unfortunately, the story that was on 60 Minutes has not held, has not been sort of carried through. So they talked about, I forget now, but people who had survived so many months or years after diagnosis, and they're all dead now. There's 2 that have survived, and the 2 that have survived probably would have survived anyway. They had a thing called IDH1 mutation positivity, and they probably would have been long-term survivors anyway. So I'm not saying that it's not the whole concept of poliovirus and using a virus to kill cells that are then, that are attached to an antibody that then attaches to an antigen and then kills the host cell. So there are good studies going on in that field, but the poliovirus study that you're referring to, unfortunately, is not looking as good as we initially thought.
Are you hopeful of something in our lifetime?
Oh no, it's not only in my lifetime. Well, unless I die in the next 2 or 3 years. But no, it's. I'm very, very hopeful that we're going to be able to keep people alive now who've got who've got GBMs now alive for many, many years. We are making huge strides. The tide is changing. The human genome has been mapped. Yeah. There's wide collaboration between Queensland, New South Wales, Victoria, in Australia, and now throughout the world, this huge collaboration. Right. So I'm very, very optimistic.
Just before we go to our next question, did you want to just add anything there, Professor Wainwright?
No, I think Charlie's covered it all.
Fantastic. Yes, sir.
Thanks. Mark McPherson, I spoke to you earlier. Thank you, Charlie, again. And panel, thank you, Professor and panel, for talking today. Just a quick question, and I realise you might not have an answer for me, but the whole mobile phone usage thing is a bit of a problematic situation, mostly for people like me in IT. And is there any evidence to suggest that the Bluetooth headsets and other things are a little better to use, or is it, the open mic and just using, holding it away from your body is probably a better choice than using some sort of headset or earphone? Is there any evidence to suggest that might help?
Yeah, no, the experts, I'm not an expert on EMR, but electromagnetic radiation, but the experts say that it's a whole lot better to hold the phone away from your head. It's better to use a Bluetooth or an earphone. They all still transmit some EMR, but it's reduced significantly the more you hold it away from your head. So to really, really reduce it to your head and your brain, 1 arm's length away from your head. And remember that it's transmitting every 5 to 6 seconds, telling base where it is. So even when it's not talking, so when you go to sleep, make sure that it's 1 arm's length away from your head, because it will still be transmitting EMR.
Yes, sir, up there and then down in the 4th row, if we can bring
My
the
name is
microphone.
Bill Sutherland. I'm a Scotsman, but I've come to live in Australia, and I'm glad of that. Now, my cancer journey began 20 years ago with prostate cancer. 8 years ago, I had a resection for gliosarcoma in PA. A week ago, I had a 3rd diagnosis for an ODG. Now, the question I'm going to ask is there any relationship between the radiotherapy that I underwent for the gliosarcoma? Has it had a long-term effect to have generated another tumour in the right side of my brain?
Thank you, sir.
Yeah, well, we do know that radiation causes brain cancer. So there's very few things that are definitively stated about brain cancer, but radiation is one of them. So we're talking about ionizing radiation. And we know those studies from, in the olden days, when radiation first came around, they used to give it to everyone. It was a panacea. And one group of patients they gave it to were kids with tinea capitis, tinea in their hair. They gave them radiation. It was great for the tinea, but terrible for brain cancer. So they developed brain cancer, and they realised then that radiation absolutely causes brain cancer, especially glioblastoma. So if you had radiation to your brain for your other cancers, I'm sure it was probably instrumental in you developing a gliosarcoma. It's not contentious. Ionizing radiation, and Brandon will confirm this. It breaks the DNA bonds. It makes all these mutations, and it does give you cancer. Yeah. Collateral damage. Yeah.
Just one thing, if I could just say something, that's a great example of one of those difficult decisions that people with brain cancer have to make around radiation, that you've only got potentially a very short time, and if you then actually, and if it's your child especially, it's really hard, but if you then go the radiation route, the fact is that in 2 or 3 years they may get a cancer of something else through the radiation. So these are all part of the
Really
difficult picture to
decisions,
choose.
aren't
Absolutely,
they?
for everybody.
Yeah, that's the... Yeah.
Yes.
Yeah.
Thank you very much for that question, sir. Can we now go to this question in the 5th row? And if anyone else has got one, yes, and we'll get a microphone to you too. Thank you, sir.
This is a little bit out of left field, and I guess I'm following on some previous questioners and something that Professor Wainwright said. What I have discovered a bit over, or just under 12 months ago, wasn't brain cancer, but it was cancer of the bladder. But what the treatment is to insert what, as I understand, a live bacillus, BCG, and something that we used to get when we were kids to guard against tuberculosis. And as I understand it, how it works, it doesn't actually kill the cancer. It stirs up the immune system, and I can tell you it really stirs up the immune system so much that your own immune system fights the cancer. Now, that's, as I said, a bit out of left field. It's got nothing to do with brain cancer, but that's obviously something they discovered.
Everything to do with brain cancer. No.
By about 40 years ago, by accident.
All right. Okay. So if I can...
No, it's good. It's great that you brought it up, because in fact it's got everything to do with brain cancer now. Immunotherapy is basically it's the concept of either using your own immune system or evoking your own immune system to fight foreign cells, cancer cells. And in fact, many of the studies, we've just started a study now out of Belgium and the US where we're trying to stimulate the immune system to fight its own cancer. So, no, absolutely, it's very topical.
Okay, thank you for that question. Yes, ma'am? Oh, sorry, yes, we've got one there.
My name is Ben Ingerman, and our daughter, my wife Liz and myself, our daughter went through a very fortunate journey with Charlie Teo. I'd like to ask the question, why aren't other people able to make a similar journey? We've met many such people since our daughter was successfully operated on by Charlie.
Thank you, sir.
Oh, look, it's
I suppose
really...
every patient is different.
It is. I mean, it all boils down to that courage thing as well. I've got so many people who've come to me like when they should have come to me earlier, and I go, "Why didn't you come and see me?" And they go, "Well, we were told not to, and we were told this and told that." And I hate to say it, but a lot of my colleagues, actively try and talk people out of coming to see me. And so it does take a lot of courage. You've got to get out of your comfort zone. You've got to go against the advice of your local doctor. You've got to move to a different state sometimes.
But why? Why aren't they saying, go and give it a go? What's stopping them doing that?
Oh, no, we better not bring that up. No, Barrie wants to stop me right there. Because
what I did want to say is this is a really important area, and it's something that I've been chomping at the bit to talk to Charlie. We will do that, but not here. But there's a whole area, and it's not just brain cancer. It's about the patient's propensity for risk.
Yeah.
And I think it's one of the areas that doctors, clinicians especially, would they've come from very medicine's so ethics. It's got really very tight ethical boundaries. But at the end of the day, and I think things are changing. But it is really important that I think they try and ascertain what the patient's propensity for risk is. Now, when somebody has brain cancer and they know that their chances of surviving are very slim, quite often their propensity for risk is really high.
Well, you
And
told
they
me
are
the
willing-
story about a little girl in France. Repeat that for me.
Well, probably the best person to tell that is Charlie. I mean, I think it's his story. I'm just parroting. This is the story about the little girl in France.
Yeah.
And you know, it's...
She was going to die. Her parents wanted her to reach Christmas.
Look, as an objective bystander, you often wonder why people don't give it a go when they're going to die anyway. But I'm telling you, I see more people not give it a go than give it a go. And the reason is because you really have to be incredibly courageous to do it.
Yeah.
I don't know, the little girl from France was the perfect example. And she was 8 years of age. All the French doctors said that it was an inoperable tumour. The mother contacted me. I said that I could operate and I'd do it in France. The French doctors stopped me from doing that. I then said, look, I'll do it in Luxembourg. The French doctors got onto the Luxembourg hospital and told them, don't let Dr. Teo operate. Eventually, I managed to get the child transferred to Germany, and I did the operation in Germany. She did very well from the surgery. She was near death, probably only days away from death before I operated. We managed to get the tumour out, and she did very well. But I must say that before I operated, I was starting to think it's all too hard. You know, it was logistically difficult. I had everyone sort of poised, ready to stab me in the back if things went badly. She had a malignant disease anyway, so I knew that I wouldn't be able to cure her, and it was all too hard. And then she wrote me this email, and please, Charlie, understand that I do appreciate what you're saying about the risk, but my wish is to spend one last Christmas with my 8-year-old daughter. And it was one of those things that I thought, oh my God, how dare I even question her desire to just spend the last Christmas. And she was fully aware, fully informed. She was making a very conscious decision to just extend her child's life, to spend one more Christmas with her. And unfortunately, you know, she didn't make Christmas, actually. I bought her about 6 months of life, but I didn't get her to Christmas. You know, she just fell short of it. But again, it's all that risk-benefit and what some people are prepared... And courage. Amazing courage on her behalf.
Right, let's go to our next question up the back. Thank you.
Hi, my name's Jess Warner. I'm from Weeper in Cape York. I was diagnosed with glioblastoma in March this year. I just wanted to find out Charlie's opinion on hyperbaric oxygen chambers and whether oxygen compression therapy can help in these kind of circumstances.
To give you a more generic answer, let me just tell you about brain cancer. It was designed by the world's most intelligent person. It is a 100% deadly cancer. Now, I know there's a lot of GBM sufferers in the room today, and I've spoken to many of you, and I've told you to stay hopeful, and I mean that. But this cancer was designed perfectly. It was designed to grow faster if you give it oxygen. If you deprive it of oxygen, it grows faster. If you cut it out, it grows faster. It's got 2 MDR genes, multi-drug resistant genes, that are present in it. So when you give it chemotherapy, it develops resistance to it. It is incredibly well designed. And that's why I think that we have to be so disruptive in the way we treat this cancer. Not the traditional ways, but we're going to have to do something very, very different. I'm really, really encouraged by the immunotherapy trials that are going on at the moment, and the way we are getting the body itself to fight the cancer. We know that GBM patients have a low CD4 count. I'm sure you all know what CD4 cells are. They're those cells that are deprived in people with AIDS and HIV. And so normal is about 1,000. People with AIDS have about 200. People with GBM have CD4 counts around 200 to 300, just like an AIDS patient. So something is going on with the immune system. Well, at Duke University, they've done studies on mice to show that all the CD4 cells are packed into the bone marrow. They just can't get out. So the brain cancer is secreting something that doesn't allow the cancer to be fought by your own immune system. Well, the good news is that if we can get those CD4 cells out of the bone marrow using a thing called GCSF, then these mice are surviving longer, and 2 have been cured. So we're starting a trial now using this concept of boosting the CD4 cells, boosting the immune system, and getting the immune system primed to fight its own cancer. And I think we're going to find that that's going to be a really, really effective way of treating it. So stay tuned. Don't worry. It's on its way.
Okay. Look, we've probably got time for about another 3 questions. Do we have one up the back? Just keep your hand up if you've got it, just so I can see. Okay, and there's 2 down here. So if we can have fairly quick questions, fairly quick responses for the last... Thank you.
I got diagnosed with a glioblastoma in February, and I honestly believe that we're getting closer every day for effective treatments and cures. I think there's things, but whenever I asked about genetic testing with my doctors, they'd say, we'll worry about that when your tumour comes back. Don't worry about it now. Is there any way that how do you go about getting you tested so that you have markers? All they told me was that I had the IDH negative. So they said, you've got 12 months to live.
Well, a very simple, quick answer is that it can be done. There are companies, they're mostly US-based, that do a whole genetic profile on your cancer for you. Of course, they have to have the tissue, so your surgeon would have had to have banked the tissue, and hopefully he has. One of them's called Foundation One. There's many of them. They cost money, but they give you a whole genetic profile. Now, that doesn't necessarily translate into better treatments yet, but at least you can get it done if you want to, and it's good knowledge anyway.
No, I honestly do. I've been doing a lot of research, reading, and I think we're very close to getting effective treatments. Not one will be a silver bullet, but I think the research that you're funding and everything will do get us there.
Yeah.
Okay, thank you for that question and the best of luck. Up the back, thank you.
I can hear you, it's okay.
Oh, good, thank you. Thank you for being here tonight. My name's Paul, I'm a GP, and for the record, I would happily refer to you, just so you know.
It's 1 in a million.
I have a question for you. 30 years ago, there were vagotomy operations for peptic ulcer disease, and then they invented proton pump inhibitors. Lens replacement operations are bread and butter for ophthalmologists, but they've just invented a steroid eye drop, which might make that irrelevant. It might be able to reverse cataracts. Do you foresee a future when brain cancer will no longer require surgery?
Can you help me
got
there,
him.
Brandon?
Well, from the complete non-neurosurgical perspective, as a cancer biologist, geneticist, by removing the tumour itself in the first instance, you basically then cut down the other things they have to kill. And so I find it difficult right now to imagine that if a tumour is operable, that you would not want to get it out straight away, you know, and debulk that tumour through surgery, radiotherapy, chemotherapy may be another issue, as quickly as possible. So
I think we'll always need tissue.
Yeah.
We'll always need tissue to examine. So I think there'll always be a role for surgery, but it may not be as aggressive as we need to do it now.
Yeah.
And so, great question. The first time I've ever seen Charlie Teo stumped.
Yeah, I was stumped then.
A quick response there, Barrie, before our next
I would just say, you know, with all due deference to the radiologists and the surgeons in the room, I think when it comes to brain, they should be options of last resort rather than first up, and that's what we all need to work towards.
Yeah. Ma'am.
Hi. It's very loud. You mentioned earlier that brain cancer is the biggest cancer killer of children, yet the least funded.
Yeah.
Why? Why is it the least funded? What do we have to do differently as a community to bring this to the attention of the government? What are we doing wrong?
Great question. Barrie.
Okay. So I actually think, you know, from a governmental perspective, and if there's anybody from the government here, they may have a different opinion, but I think the reason why the funding has gone as it is quite understandable, because the government has gone for the high incidence cancers to begin with. And that makes perfect sense. I mean, let's be honest, I wouldn't be up here and knocking that. So it makes sense to go for the ones that affect the most people, and that's what's happened. What we do know from that is the cancers like breast in adults, like leukemia in children, to some extent prostate and others, the focus and the funding that they've had has had a tremendous effect on survival and has increased it tremendously. So things like breast cancer, prostate, now 9 out of 10 people will survive for 5 years, and the same with kids with most leukemias. Now, what we need then is we need the focus and the funding, because what we do know from that experience is we know it works. We know if you get the funding and the focus, you will change survival. So, and we're working hard to do that, and things are changing. I wouldn't say we've got the funding yet, but there's a greater awareness in government. We've been working hard with them, and governments, including the Queensland government, are becoming aware of the need. And one of the really interesting stats I saw recently was mortality, deaths from the more common cancers has just crossed with those of the rarer cancers, which is a really interesting one. And there's a very good advocacy group called Rare Cancers in Australia who've put this statistic out there. And so I think that's changing the focus of people, where they think, well, maybe, that doesn't mean say we need to take the effort away from the other cancers, and I wouldn't ever say that, but it means we need to maybe rejig the balance a bit and focus more on brain.
Okay, and
just quickly, I think it's also worth noting that brain tumours are a very much under-researched area, because there actually aren't that many active researchers in Australia, which is one thing that we are trying to address through the generation of fellowships and salaries for promising young researchers who may be, you know, active in a field that isn't brain tumour research, but have got great skills and great opportunities, and actually say, well, hey, here's an opportunity to come and work in brain tumour research. So, you know, there's a bit of a workforce issue here too, because there just in Australia there just aren't that many brain tumour researchers.
Yeah. And our last question, sir.
Hi, Andrew Hamilton, a GBM 7 years ago, and scans are clear. I'm not showing off. I'm just simply asking the question: do we need some sexy people? Because let's say breast is sexy. Brain is kind of mushy. So Carrie managed to put it up onto up into the lights for us, but do we have anybody who's going to be the shining light, the face for brain cancer and for research?
What's your name?
Where do we get the money from?
What's your name?
Andrew Hamilton.
Andrew, congratulations. And congratulations. And from a media perspective, Andrew is spot on, isn't he?
Yeah, he is.
That's exactly what you need, the political will, the debate, the community to get behind because they know that person or they, you know.
Yeah. Unfortunately, you know, most people die quickly from brain cancer. And, you know, I've operated on some high-profile people who I thought initially would be fantastic ambassadors and sponsors and speakers and advocates for us, but they all died. You know, people like Stan Samanik, who was a disc jockey, Chris O'Brien, who was a celebrity TV doctor, and you know, all those people would have been fantastic advocates for us, but they all died.
Well, do you know what? That was my last question, and I'm not going to leave this on that thought. So I want you to say something positive.
No, well, there's a positivity, Andrew.
We should have had you up here. Ladies and gentlemen, when you have a sensational panel like this, you're always going to run out of time, aren't you? So could you please put your hands together for Professor Teo, Barrie Littlefield, and Professor Wainwright.
Thank you.
And you know, to steal from Andrew again, the only way the profile of brain disease will increase is if we all continue to talk about it. And I encourage you to carry on that conversation outside this door, online, in your communities. There's no better time to start too than during National Science Week. Professors Teo and Wainwright and Barrie are here. They're around for the next 10 or 15 minutes, and they would love you to come up and say hello. So if you didn't get to a question or you would like just to shake their hand and say thank you, I know they'd really welcome it. Thank you for coming. Thanks for your involvement, and good night.